Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. This is Abir Khaja, Neurology Assistant Professor at King Abdulaziz University. Thank you for joining us today in one of the activity of the Saudi Epilepsy Society titled Anti-Seizure Medication Cognitive and Behavioral Profile. It's my pleasure to present our speaker for today, who was my mentor during my residency training, Dr. Haytham, Professor of Neurology, Neuropsychiatry, and Epilepsy at King Abdulaziz University. He graduated from medical school in 2003. Then he joined Miguel University for his neurology residency training and graduated in 2010. After that, he continued his fellowship in neuropsychiatry and epilepsy at Harvard General until 2014. Currently, in addition to his academic role, he is the founder head of epilepsy unit at King Abdulaziz University. And he's a member of the Saudi Epilepsy Society Board. The talk can be more about Dr. Tayyib. However, we will start our topic. So, Dr. Haytham, the mic is yours.
Thank you very much, Dr. Abir. I take pride in being your mentor in the past, and I take more pride in learning from you today and in being with you. So thanks a lot. Thank you for the Saudi Epilepsy Society for organizing this and for the organizers as well. Let me see if I can share my screen. I think we are good to go. All right, so I was asked to speak about cognitive and behavioral profiles of anti-seizure medications. It's one of the more practical topics that many of us neurologists deal with on a daily basis, not just in epilepsy clinics, but also in general neurology clinics, and even in psychiatry clinics, maybe even in internal medicine clinics where some of anti-seizure medications are used for neuropathy treatment and migraine prophylaxis and various other things. And oftentimes the cognitive and behavioral effects of anti-seizure medications are viewed as an on-the-side thing, as an extra to the clinical visit, with the main focus being given to the seizure burden, for example, or to the headache burden and so on and so forth, and very little time of the clinical encounter allocated to the cognitive and behavioral effects of the medications we're prescribing, even though these might just be the main determinants of the person's quality of life and clinical outcomes. It wouldn't make much sense to rid somebody of their seizures only to have them suffer from resulting depression or even thoughts of suicide as a result of the medications we are giving. So the topic the importance of the topic cannot be overemphasized, and it's my pleasure to review some of the literature. We are doing at our epilepsy unit a couple of clinical studies that are ongoing but not ready yet for publication. But we will share some of our experiences as well as is relevant. I encourage people who are attending to ask questions. It is tough to gauge the audience backgrounds and so on. So I welcome all questions. If there are things that we can discuss and clarify that were not mentioned, or even learn from you folks in the audience, it would be great. Before we begin, I have no immediate disclosures at the moment. We have various drug companies attempting to establish research collaborations with the epilepsy unit, but none of this lectures contents are affected by any of the potential future collaborations. The objectives of the talk are to discuss the relationship between different anti-seizure medications, behavior, and cognition, and we'll try to have a practical approach. We will not necessarily cover pediatric issues in depth, since pediatric epileptologists might be better positioned to do that. We'll mention a few things, though. We will try to answer some of the questions relating to the behavioral cognitive effects and how we can predict them and anticipate what happens when you prescribe and manipulate anti-seizure medications of a patient. We will try to answer the question of how to take into our advantage, not to our disadvantage, the cognitive and behavioral profiles of anti-seizure medications. We will ponder the question of whether suicide is a risk when prescribing anti-seizure medications, and whether there are benefits from prescribing anti-seizure medications from the psychiatric standpoint. All right, so the issue of cognition and behavior is so deeply intertwined with epilepsy in a complex fashion. Epilepsy is well known to be associated with behavioral and neuropsychiatric complications, as well as cognitive complications. Things like inattention, amnesia, aphasia, slowed thinking are frequent complaints often voiced by epilepsy patients, and mood disorders, as well as irritability, insomnia, reduction in the quality of life, are also as frequently voiced by our patients. And it goes so far back in recognition that people like Sir Thomas Willis commented on epilepsy causing cognitive dysfunction. And in fact, even the name seizures is partly related to the behavioral appearance of how seizures are and their connection with potentially demonic possession and so on and so forth. And the linking, the relationship between seizures and epilepsy from one side and psychiatric and behavioral symptoms on the other side stems from many things. Number one, possibly from shared etiologies. So epilepsies often affect temporal and frontal circuits that also subserve cognition and behavior. Not just their job is obviously not just to cause seizures, and therefore there are underlying similarities in localization between psychiatric syndromes and epilepsy oftentimes. And then there's what we all epileptologists know too well, with seizures causing ictally or post-ictally or inter-ictally contributing to behavioral and cognitive symptoms. And last but not least, our anti-seizure medications also have negative effects on behavior and cognition by virtue, and it makes sense because they act centrally. And just like any other medications, they may have side effects of what they do to the brain. And of course, behavioral effects can lead to cognitive dysfunction. Depression is well known to be associated with inattention and cognitive dysfunction, and cognitive dysfunction can impose significant stressors and cause anxiety and mood symptoms as well. Having said that, it's not all bad. Anti-seizure medications, just like they cause negative effects on cognition and behavior, they also cause positive effects on cognition and behavior. They are positioned to, first and foremost, by reducing the seizure burden. And it has been shown that when the seizure burden is reduced, cognition, behavior, psychological outcomes, and quality of life all improve. Furthermore, when anti-seizure medications are carefully selected, we can optimize a patient's condition in so-called cocktails that improve cognition and behavior. So let's delve into some more depth. How do anti-seizure medications alter cognition and behavior? Some of the effects are idiosyncratic, meaning they could happen in some person, but not in the other person. And it so depends on factors, on patient-related factors that we will discuss, some of which in the next couple of slides, but we may or may not be able to completely predict in the patient in front of us whether a particular psychiatric or cognitive side effect is going to take place or not. Of course, like any side effect of any drug, dosing has a role. So some of the side effects are dose-related. Toxicity may lead to some side effects emerge only in the context of toxicity or withdrawal of medications. Some side effects emerge only when there are drug-drug interactions. For example, some of our enzyme-inducing anti-seizure medications reduce levels of some psychotropics, and there are also compounded effects of some medicines. So, for example, the negative effects of, say, topiramate are worsened, or Laviteracetam may be worsened in the presence of other medications that lead to similar side effects. So one wants to consider drug-drug interactions when prescribing, and this is what we call rational prescription of anti-seizure medications, and this applies to cognitive and behavioral goals as well. There are behavioral manifestations of physical side effects. So, for example, if you give somebody with topiramate, with epilepsy, a topiramate, and they have the usual tingling, that alone may be sufficient to cause them to freak out and have anxiety and panic attacks. And that's not a direct effect of the medication. It's more a response to the physical side effect of the medication. There are other hypothesized phenomena that may underlie the pathophysiology of cognitive and behavioral effects of anti-seizure medicines. One of them is the release phenomenon. When anti-seizure medicines block or suppress certain neuronal networks, these neuronal networks sometimes rebound and cause what we call release phenomena. So if perceptual networks are suppressed for a while, as soon as they find the chance and emerge from the power of the suppression of anti-seizure medication, they may cause visual hallucinations or auditory hallucinations, and so on and so forth. More famous is the process of forced normalization, which we will talk about in a little detail, which posits that when you remove seizures, you remove some of the negative effects of the positive effects, or presumed positive effects of seizures on mental status, which is a very provocative statement, and we'll try to discuss that in more detail. So let's try to answer the question: which of our patient populations are more ready for harm or benefit? Patients who have previous psychiatric conditions or family history of psychiatric problems are amongst those who we need to be paying careful attention to psychiatric and cognitive profiles of our medications. It has been demonstrated and documented that people with prior history of a certain psychiatric symptom are likely to experience the same psychiatric symptom upon prescription of a medication that causes it. So, for example, if a patient of yours has past history of anxiety and you are about to prescribe a medication that causes anxiety, they are more likely than those who don't have anxiety to experience anxiety. So prior psychiatric profile of your patient is of importance. Along that line, history of intellectual disability or learning disorders is a risk factor as well, especially for aggressiveness and irritability and impulsivity upon prescription of medications that may cause that. And what about the seizures, the epilepsy type and the seizure type? The more generalized focal seizure if a focused seizure secondarily generalizes, or if there is a tonic seizure or an absence seizure, that is a risk factor for having cognitive and behavioral side effects. Intractability, so people who have intractable seizure disorders are at risk. Having said that, people whose epilepsies are easily controlled, or whose epilepsies become controlled, are also at risk because of the phenomenon of forced normalization that we will talk about. People with temporal lobe epilepsy are particularly prone to all kinds of neuropsychiatric sequelae, either as manifestations of their epilepsy or as side effects from surgeries or from medications, and so on and so forth. So these are important points to elicit in a patient, in the history of a patient with epilepsy, before embarking on anti-seizure medication prescription or any intervention for that matter. So this phenomenon of forced normalization is as old as when it was described by Landolt in 1958. The diagnostic criteria look something like this. You have to have an established diagnosis of epilepsy, an acute onset behavioral disturbance, you call it whatever, psychosis or affective disturbance, or even conversion-like symptoms, aesthesia, abasia, something that emerges out of a background of absence of these symptoms. And the crucial point here is recent control of seizures, either a reduction of electrographic markers of epileptiform activity or complete seizure freedom clinically. And there are several explanations for why people whose EEGs and clinical seizures improve get better. And they're all hypotheses that are based on the fact that when we treat people with ECT, electroconvulsive therapy, their psychiatric symptoms get better. We give them seizures and they get better from the psychiatric standpoint. And what happens is that the hypothesis that there was something underlying that the seizures were treating, or that when we force the EEG to normalize, and that's where the term forced normalization comes from, we get alternative symptoms, alternative psychoses to the previously felt seizures. There are so many neurobiological, neuroscientific postulates explaining that in terms of neurotransmitters and so on and so forth. But one can't shake, and the literature does not rule out the possibility that what happens when you treat seizures that were previously obvious is that you just modify their semiologies. And instead of people falling and convulsing or having flagrant focal seizures, they have more limited activations cortically that are not apparent on EEG. So this normalization criterion it is largely dependent on scalp EEGs. And we know that if people have focal aware seizures, they may or may not have an abnormal EEG, and that leads people to the assumption that whatever they're experiencing is not actually related to epilepsy or to seizures, or as in fact it may be. Another point is that at the time that the concept of forced normalization was coined, and it does linger until today, but at the point that it was described, people did not really give deep thought to the possibility of the medications themselves being causative of psychiatric symptoms. So in fact, the appearance of psychiatric symptoms upon seizure reduction may just be a marker for potency. This medication is working. It's removing your seizures, but it's just causing side effects. And this seems to be, using Occam's razor, this seems to be the more logical explanation. Having said that, the phenomenon does linger, and it is associated with these medications more than others. In cases where your seizures abate on topiramate or Laviteracetam, which are the two most used medications among the list, of vigabatrin and ethosuximide, consider the possibility of forced normalization. And they are rare with lamotrigine, gabapentin, and pregabalin. So that's forced normalization. I have never personally, I was never convinced with the possibility of forced normalization in any of my patients. It's tough to rule out any of these other possibilities that I mentioned. And one wants to be practical when altering their anti-seizure medications anyways. So anti-seizure medications fall on a spectrum between being sedating, hypnotic, and activating, stimulating, or even causing insomnia, being anxiolytic, reducing of anxiety, and being anxiogenic, causing anxiety, being depressant, anti-manic, or antidepressant, potentially mania-inducing, being propsychotic, causing psychosis, and being neutral. I suppose no one can say that, there are no known antipsychotic effects of anti-seizure medications that come to mind. And then there's also a spectrum between being impairing of cognition and being neutral or slightly improving of cognition if you consider this indirect effects on cognition when you control seizures. And it has been postulated by Trimble and others that these things go together, and it fits clinical experience that this group of effects go together, and this group of effects go together, and this may be related to underlying ultimate effects on excitatory and inhibitory neuronal circuits. So GABAergic agents. So, for example, things like barbiturates and benzodiazepines, vigabatrin, gabapentin, topiramate, and so on, belong to this category. Whereas other agents, for example, that are belong to the anti-glutamatergic category. So one improves inhibition, the other reduces excitation. It is hypothesized that the GABAergics are more likely to cause things like depression and psychosis than the anti-glutamatergic group. Having said that, it has been a tendency in psychiatry to link symptoms and syndromes simply to neurotransmitters. Parkinson's disease is the easiest disorder in the world to link to neurotransmitters. And there have been attempts to do so for Alzheimer's disease, and there's some success leading to the acetylcholinesterase inhibitors. And epilepsy comes next, right? We speak of our medications directly acting on neurotransmitters. However, modern perception of neuronal function goes beyond neurotransmitters, right? We speak of neuronal circuits and circuit localization, and we often utter the phrase epilepsy is a network disease and not a neurotransmitter, not limited to one neurotransmitter or to one focus. So I am brave enough to try to link vaguely and with lots of caveats some of our neuropsychiatric and cognitive syndromes to neurological localizations. So we know that right hemispheric lesions, especially temporal, are more associated with psychiatric complications, including psychosis, for example. Left hemispheric ablative lesions are more associated with depression, and right hemispheric ablative lesions are more associated with mania. Mania is missing there. Psychosis is viewed as a hypofrontal hypertemporal disorder, meaning you can see psychosis as ictal manifestations of mesial, temporal, or limbic circuitry, or you can see it as a result of hyperfrontal frontal dysfunction. Cognitive dysfunction is oftentimes linked with, in epilepsy, is oftentimes linked with mesial temporal dysfunction or frontal subcortical dysfunction. And there's a hypothesized and understated role of cerebellar dysfunction that possibly underlies many of the effects of our anti-seizure medications. The cerebellar cognitive affect hyperactive syndrome has been popularized by Schmaumann over the past decade. And we know that our medications, many of our medications affect cerebellar circuitry and therefore may lead to, may underlie some of our negative psychiatric and behavioral effects. So as I go through some of the medications in a hopefully a practical manner, I try to position these boxes in a way that makes it easier to remember. Whatever is up here is more on the activating irritability, anxiety, insomnia side. Whatever's down here is more on the sort of negative side of things, depression, sedation, and so on and so forth. This is, you can think of this area as your right hemisphere, this area as your left hemisphere. So depression is a left hemispheric lesion. It just helps you remember these things, and it sort of reflects how I think of them. And if it helps, so be it. So let's talk about the medications one at a time. Barbiturates, we won't spend a lot of time. They are not as frequently used as they used to. They are well known for causing sedation. Very few medications have disorders linked to them. Barbiturate coma is a good example because of barbiturate's narrow therapeutic window. Sedation is a frequent problem on the behavioral front. Depression is also a frequent problem reported in the literature, and it's linked to the Gabaergic effects of barbiturates. Inattention is a problem, and it is reported in school children on barbiturates to have symptoms similar to ADHD. Barbiturates have a long half-life, and their withdrawal is a problem. Upon withdrawal, symptoms of insomnia and anxiety may take place, and they are also notorious for drug-drug interactions, potentially reducing your levels of many of the psychotropic medications that you may need to prescribe for your patients. Phenytoin is better than barbiturates in terms of its risk of sedation, but this is not eliminated. It does have the withdrawal effects, although the half-life is somewhat more manageable. There is the term Dilatin Dementia, referring to the encountered bradyphrenia, slowed psychomotor activity and slowed thinking, and memory retrieval problems, and short-term memory loss associated with use of phenytoin, which is a problem that we see in the clinic. And particularly when toxic, phenytoin can cause a schizophrenia-like psychosis. We know that phenytoin toxicity often presents itself with confusion and cerebellar signs, but when it presents itself with psychosis in the context of toxicity, oftentimes this is without the presence of cerebellar signs, making it important to recognize the possibility of this syndrome. There are other GABAergic medications with similar profiles. The pregabalin and gabapentin are useful from the anxiolytic standpoint. Pregabalin is less sedating than gabapentin and is not reported to be associated with some of the depression that is reported with gabapentin. Obviously, both can be a problem in people with chronic kidney disease, as they may accumulate really quickly because of their predominant renal, exclusive renal excretion. Vigabatrin, which we in adults rarely use, is notorious for depression and psychosis. Clobazam, which acts like a benzo because it is a benzo. It is, however, a partial agonist, so it solves some of the sedation problems that you have with people in whom you have to put on benzos for long term because of how refractory their epilepsy is. So GABA is blamed for a lot of the problems that cognitive and psychiatric problems, at least it has been blamed in the literature. Carbamazepine is well known as a mood stabilizer. It is predominantly an antidepressant. It looks like a tricyclic antidepressant, in fact. So that is a positive. Depression is rarely, you rarely, if ever, see depression in people who are taking carbamazepine. You sometimes, or you rarely see mania, not depression. Carbamazepine does cause cognitive issues, somewhat similar to what you see with phenytoin, with subcortical cognitive impairment and attention issues and memory retrieval difficulties. People look a little delirious. And some of these problems were fixed with oxcarbazepine and eslicarbazepine, the later reiterations, incarnations of carbamazepine. However, this is at the expense of a worse psychiatric profile. So you have less in terms of cognitive side effects, but you do see depression and less of a mood stabilizing property with, especially with eslicarbazepine. Oxcarbazepine does have mood stabilizing property, but we didn't get rid of any of the cognitive dysfunction that you see with carbamazepine. Valproate is the other famous mood stabilizer in our arsenal. Valproate encephalopathy is the commonly known side effect of valproate. It is rare, but it is potentially dangerous. It is linked with dysfunction in the urea cycle because presumably it was thought it was because of high ammonia. However, it has been frequently reported without an elevation in the ammonia. So if you have somebody who started on valproic acid who becomes encephalopathic, you are sure they're not seizing. Their EEG looks like it's got large amplitude, slowing bilaterally. They are confused. You should consider urea cycle dysfunction and acute valproate encephalopathy. In which case, what I would do is just simply get rid of the valproate if I can. Carnitine is reported to help. However, I wouldn't bet on it, and I wouldn't certainly give it too long to work if my patient did not look well. Topiramate, the presence of topiramate increases the risk of valproate-induced encephalopathy. Valproate can also cause a subcortical cognitive impairment. Sometimes it even causes patients to look like they're severely psychomotorically retarded, as if they have Parkinson's disease. Sometimes they even have valproate is well known to cause tremors. In children, some of the stuff that we know about valproate in the past decade is that it's not good for, we obviously know its teratogenicity, but even if kids escape, the babies escape from teratogenicity, and if their mothers were exposed to valproate, they are at risk of having ADHD, and they're at higher risk of developing cognitive problems and lower IQs later on in life. Now, when you look at Lamotrigine, the lower half of the screen is empty. The upper half of the screen is where things are. So Lamotrigine is activating. It sometimes, in fact, insomnia is a problem with Lamotrigine, and irritability is a limiting factor. Rarely it's sufficient that people will ask for discontinuing the medication. Lamotrigine is an antidepressant. It has well-known antidepressant properties, and therefore it is used in bipolar disorder, and it's helpful for that. So, and we have a favorable cognitive profile here. We don't see a lot of cognitive dysfunction, a lot of the subcortical cognitive dysfunction that we've previously talked about with, so far, carbamazepine, valproic acid, phenytoin, and phenobarb. All right, the mother of all evil, or the father of all evil, topiramate. Topiramate is a broad spectrum, so-called broad spectrum anti-seizure medication. It's plagued with side effects. People frequently report adverse cognitive and psychiatric events. This is and you have things on the upper side of the screen, things on the lower side of the screen. People can have anxiety, irritability, like you would see in your typical patient with Laviteracetam, and people can have depression, and people can have psychosis. The other iteration of topiramate, or the close cousin zonisamide, is plagued with similar problems or even worse. So this is a major issue with these compounds. The other issue at the cognitive side is that it causes notorious word finding difficulties and memory retrieval difficulties, and there's a relationship between the two. So if your patient develops word finding difficulty, don't shrug it off easily, because there's evidence that links the two. Your patient with word finding difficulty is not unlikely going to develop mood symptoms later on if you don't pay careful attention to that, or even psychosis. And the psychosis that develops with topiramate is full-blown psychosis with auditory hallucinations and paranoid delusions, and it's the type that people call the police for, because they think people are coming after them, and so on and so forth. So topiramate's profile was compared with many of the other anti-seizure medications, and it's worse than most of them, including so if you compare topiramate with someone that's older generations, like medications like carbamazepine, topiramate will fare worse. Laviteracetam is another medication whose psychiatric effects are plaguing. Perhaps it's the only vice of Laviteracetam which does not have any other side effects to speak of, essentially. But the psychiatric complications, including most commonly anxiety and irritability, are problematic, and they are seen in up to 25% of people. I typically tell people that in 10 to 20%, you are likely to experience anxiety or irritability. In 1 to 2% chance, this is going to be very severe. As a matter of fact, the data tells us that 1 in every 4 people who experience psychiatric side effects with Laviteracetam is going to discontinue the medication because of that. So this needs to have its fair share of discussion in the clinic. Depression is also a problem. People also, when depression is severe, people can report thoughts of suicide. Psychosis also happens. In 1%, it may seem like a small number, but psychosis is a potentially very significant side effect. Having said that, Laviteracetam has a favorable cognitive profile. It's not associated with significant cognitive deficits. It's only minimal cognitive deficits are often reported with Laviteracetam. The later reiteration, Brivaracetam, is associated with less prevalence of irritability and anxiety and so on and so forth, and maintains the good cognitive profile that we see with Laviteracetam, presumably because of the more selectivity of Brivaracetam at the SV2A ligand, and its lower effect on or no effect on AMPA receptors. And so this efficacy leads to lower dosing and more selective effects that render Brivaracetam give it a better profile. So which of your patients on Laviteracetam, which is arguably the most prescribed medication here, around here, is likely to have cognitive or psychiatric side effects? So this was looked at recently in a systematic review, going through meta-analyses and many trials. And the variables listed here were all individually associated with higher risk of developing adverse events. And the ones that are highlighted in green here are the ones that came out in the regression analysis with positive p-values. And we've mentioned a few of them, including the previous presence of psychiatric symptoms, intellectual disability, although it did not come out to be significant in the particular regression, regression. Previous status epilepticus is also something that you should consider as a risk factor, and it tells you that the network dysfunction is more severe. And then it's important to remember that having phenytoin or lamotrigine on board along with laviteracetam increases your risk of developing cognitive and psychiatric side effects. If you switch to brivaracetam, will this improve? Will your patient's cognitive and psychiatric symptoms improve? The answer seems to be yes. The proportion of your patients with cognitive and psychiatric symptoms that improve will range from 33% to 83%, with good stability over time. So there does seem to be sufficient evidence for switching from laviteracetam to brivaracetam. All right, Lucosamide looks hot on this slide with a favorable profile, no cognitive deficits, no risk of depression. Rarely depression is reported with Lucosamide, and this is not because of lack of data. I took this out of one of the meta-analyses, and you can see how there's very little in terms of adverse events, and the profile is definitely better than some of the newer agents, and at least the same as lamotrigine in terms of depression risk. So always consider Lucosamide in patients whose profile may make you anticipate the occurrence of adverse cognitive or psychiatric events. Perampanel is no longer the new kid in the block. It's been around for a while now, and we have some experience with it around here, and we may be running a clinical trial at our center at some point. And even though it has a favorable cognitive profile, as reported in its trials, it's plagued with behavioral side effects. Irritability is a problem. There are even more significant problems, even though there's no psychosis here. Violent thoughts and homicidal thoughts are a problem in 0.1% of people. And this needs to be taken into consideration. Patients need to be counseled about it. Depression is also a problem. I have already had to stop perampanel in a few patients because of these symptoms. And even though it has a lot of, previously refractory patients responded or improved on perampanel, sometimes these side effects are a limiting factor. This is also from one of the meta-analyses summarizing the evidence for you. So if you look at, you have brivaracetam, laviteracetam, perampanel, and topiramate, and you have their comparisons in irritability, anger, and aggression, and you'll see that perampanel does not do well in comparison to laviteracetam in terms of irritability scores. Even topiramate does better in this set of data. So this is not to be taken lightly, and it's the highest in terms of its potential to cause aggression. Brivaracetam doesn't do too badly. So these are the main things that one wants to keep in mind. But one wants to also keep in mind that there are caveats. The literature describing the side effects is heterogeneous. We have all kinds of things. We have a lot of data retrieved from retrospective chart reviews, and people know the limitations of that and whether things are documented or not. Not all studies use neuropsychological or well-known tools to study these symptoms. There are many case reports and case series, especially when it comes to rare things like psychoses. And there's rare in terms of randomized placebo-controlled trials, except for those medications that got approved recently with their recent and well-known trials. These are some of the problems with the studies. You have people differed, the studies differed in how they reported the cognitive side effects. Things range from self-report to using neuropsychological tools. Duration of follow-up is different, and even who was studied is different. And sometimes all these data are lumped together. It's like the problem with the earlier problem with stroke. So 30 years ago, studies of stroke lumped patients with stroke together, and I guess this is partly the importance of having a proper classification that is followed with clear use of language when studies are planned. However, one can keep lists like this in handy. So this is made by my friend, and it's courtesy of Dr. Weisholz from Boston, and I modified it a little bit. So you have a list of medications that are likely to cause hyperactivity and agitation, irritability. You want to keep that in mind. You have a list that can cause anxiety. You want to keep that in mind. And the list that causes depression, you want to keep that in mind. And a list that causes psychosis, and you want to keep that in mind. You know, it sort of brings you back to medical school and how you want to remember these things. You can keep this in your pocket. You want to, whatever you do, this needs to stay in hand as you're prescribing medications to our patients. You can at least remember what's better and what's worse. So there is a list of medications that's better for cognition, and there's a for behavior in this slide, and there's a list of medications that are worse that you want to avoid in people who have behavioral problems or who are at risk of behavioral problems. And the same thing goes for cognition. There are medications that are better for cognition, and there are medications that are worse for cognition. So you want to keep that in mind. Getting close to the end, it has been a problem that elicited by the US FDA in 2008 when they linked anti-seizure medications with suicide. They had a sweeping meta-analysis that found that there's an increased risk of suicide right of the median, with increased odds ratios for all anti-seizure medication. And they call this a class effect. This caused a lot of commotion, especially when suicide is being talked about freely, and patient advocate groups are speaking about this. So it causes problems and limits compliance and so on and so forth. But this meta-analysis is plagued with problems. So there are a lot of heterogeneous variables, and psychiatric morbidity was not necessarily clearly elucidated. So, and I guess the presence of psychiatric morbidity in epilepsy should be logically considered the main risk factor for suicide here. And subsequent findings after the meta-analysis, this meta-analysis was inconsistent, the last of which was very recent, looking at some of our newer medications and finding no evidence of increased risk of suicidal ideation or suicidal attempts. And this is just a synopsis of the benefits that you can have with anti-seizure medications from the psychiatric standpoint. This is mostly taken from the psychiatric literature. So, for example, we know that valproic acid is useful in acute manic episodes, but we don't necessarily know that the same thing goes in people with epilepsy. So valproic acid is a mood stabilizer for sure in people with bipolar disorder. We don't know for sure whether it's a mood stabilizer in people with epilepsy. There's not enough evidence to demonstrate that. Carbamazepine is also used as a mood stabilizer, like we previously mentioned. And these two agents, the evidence of their usefulness in bipolar disorder is oftentimes used and extrapolated to justify their use in people with irritability and aggression, kids with autistic spectrum disorder, and an intellectual disability who have impulsivity and behavioral dyscontrol, and even in elderly individuals with epilepsy and dementia, which is another area of connection between behavior and epilepsy. Epilepsy physiology being a potential pathogenic mechanism for things like for a disorder like Alzheimer's disease. So these medications are sometimes used to control behavioral dyscontrol in these situations, even though a Cochrane review did not find significant effects for these agents to control agitation and so on in these contexts. But they're being used and without benefit, without evidence. All right. We'll go. This basically ends the talk, but let's go through some of these cases together. I have 3 cases just to put it all in clinical context. So this is a 21-year-old male with history of ill-defined episodes of loss of awareness and aggressiveness. This is a recent case that Dr. Abir may remember. This patient came to clinic and he had these episodes of loss of awareness and unresponsiveness without falling to the ground, just altered perception of things around him. And sometimes he would be aggressive and would hit his family members and so on and so forth. He came to our clinic. We were not convinced with the description. We had an ambulatory EEG done, which was normal. Later on, however, he came to the emergency room with convulsions, and in the emergency room, he was loaded with Laviteracetam. This raised the question of whether or not he actually had epilepsy, and whether our ambulatory EEG did not capture any of those suspicious events, and whether some of his violence may be post-ictal. So we shifted him to the EMU for characterization, and in the EMU, he was floridly psychotic, having audiovisual hallucinations, command hallucinations, attending to stimuli, to visual and auditory stimuli, and he was somewhat violent. During this time, his EMU LTM is normal. So one can ask themselves, what would you do now? One will find themselves wondering whether everything we're seeing now is just post-ictal, and he has post-ictal psychosis because he may have had a convulsion. But one should also consider the possibility that this may be Laviteracetam-induced psychosis, which, like we saw, is an important potentially limiting side effect. So what we did was that we removed his Laviteracetam, stopped it, did not diagnose epilepsy. This patient was not previously in status epilepticus. We gave him close follow-up and a referral to psychiatry. When he was in psychiatry, a couple of weeks after Laviteracetam was discontinued, he was not psychotic at all. He did, however, have a convulsion witnessed by the psychiatry clinic staff. And they thought that it was a genuine convulsion, like a generalized tonic-clonic seizure. So what would you do now? Does this patient have epilepsy or not? They ended up sending him, think about what you would do. This patient is now on no anti-seizure medications. He is not psychotic. Was that because you stopped the Laviteracetam, or was that because he was post-ictally psychotic when he was in the EMU, took his time to improve, and so on and so forth? So these are very hard questions to answer sometimes. What ended up happening here is that he went to the emergency room and he was loaded with valproic acid. Later on, he had events that seemed to be non-epileptic, and the valproic acid was discontinued. We later on enrolled him in our joint neurology and psychiatry clinic, which we have been having for the past year in the presence of neurologists and psychiatrists, discussing the patient and inviting the patient in. And we so far maintain him on no anti-seizure medications. He continues to have these ill-defined episodes, and psychiatry may be leaning toward treating him with an antipsychotic medication, but the diagnosis is still unclear. And the reason why I mentioned, why I brought this case up is that because it is important to consider all factors here, which goes back to the very first, my very first point, which is that there's a strong relationship between neurological and psychiatric symptoms in people who have epilepsy or even those who may have epilepsy. Let's look at this other case. 55-year-old male, 6 months after having had a left anterior temporal lobectomy for left temporal lobe epilepsy, is seizure-free. He remains on his pre-surgical medications, Carbamazepine, Laviteracetam, Lamotrigine. He had no prior psychiatric history other than having had post-ictal psychosis a couple of times. He was seen in the clinic 6 months after, and he looked exactly like somebody with mania, with bipolar disorder, with overconfidence, grandiosity, history of overspending, and so on and so forth. What would you do? So, you would consider several things. First, you should ask yourself where these symptoms are coming from. You want to think whether these are potentially related to ongoing seizures. So you get an EEG, and his EEG is normal during these symptoms, and you scrutinize the history, and there are no well-defined episodes. You ask yourself whether this is a side effect of his surgery. We know that some of these symptoms are reported post-surgically in a minority of patients. Mania, in particular, is seen in 5 to 10% of patients post anterior temporal lobectomy, more commonly seen in people who receive right temporal lobectomies, not left temporal lobectomies. And this is a right-handed patient. And then you want to consider whether or not he's on the favorable medication regimen here. And you see that he's on Carbamazepine, Laviteracetam, and Lamotrigine. And, if he were on Carbamazepine, you would say, oh, well, we know that this is an antidepressant. It can cause mania. But he's on Carbamazepine, which has a similar profile. So what we ended up doing was we had to treat him with quetiapine, and we stopped his Carbamazepine because of that piece of information. We optimized his medications in order to maintain seizure freedom, and his symptoms improved. 3 years post-surgery, he is seizure-free, but he did have recurrent and alternating mood episodes. Now, you are compelled to think whether something happened in his brain subsequent to the surgery that made him more liable to manifest bipolar disorder. And the only potential risk factor is the presence of post-ictal psychosis previously. So once again, this case demonstrates how there is a strong relationship between the two. So what we ended up doing here is continue to treat him with mood stabilizers and antipsychotics and pull away on Laviteracetam. Third case and final, very quickly, a 21-year-old with IgE. He was difficult to control. She was started on Laviteracetam with partial control. Lamotrigine was added. She had better control, but she was still having seizures. Topiramate was then added with significant effects, rendering her immediately seizure-free. However, she had intolerable symptoms. She had depression and forgetfulness, and which is, you were not surprised, right? What would you do now? She's now on Laviteracetam, Lamotrigine, and topiramate. Would you come back on the topiramate because you know that it does cause whatever you want to blame it for? But at the same time, you know that she's now seizure-free. So what we ended up doing here is pull back on the Laviteracetam, actually, because we know that people are more prone to having Laviteracetam-induced side effects in the presence of Lamotrigine. And we know that topiramate is now important for us in terms of seizure control. So you pull back on the Laviteracetam, we'll keep the Lamotrigine and topiramate, one being activating, one being a little sedating on the Gabaergic side of things. Like we previously said, she ends up being seizure-free and mentally well. So these are the take-home points. Psychiatric and cognitive effects are common with anti-seizure medications, and it is important to distinguish those that are drug-induced from other causes of neuropsychiatric morbidity and epilepsy. Drugs have profiles that should be kept in mind when you're manipulating the medications. Patients should be monitored closely for psychiatric illness during the 3 months following temporal lobectomy, particularly those with significant psychiatric history. And more work is needed in order to get down to the underpinnings of the psychiatric symptoms. And my favorite is that there is no neurology without psychiatry and no psychiatry without neurology, especially when it comes to epilepsy. Thank you.
Thank you, Dr. Heatham, for the comprehensive talk and covering this important aspect that sometimes missed in the general neurology in the basic clinic. So we have a couple of questions. We'll start with the first question. So what's your expert opinion about Laviteracetam associated aggressive behavior and anxiety?
Yeah, so like we said, it's a problem that plagued Laviteracetam, and it's the only problem you have to talk about. I don't know what your experience is, Abir. What I do is, if it's one of the 10 to 20% people that report a little bit of irritability, I try to reduce the dose if possible. And then there's some evidence that adding pyridoxine helps, mainly derived from pediatric literature. So I do that, but I don't wait for a long time. So one visit, the next visit, I basically switch to another agent. That's what I do in a nutshell. Not sure, is that what you do? Is that what other people do?
Actually, according to the significant or how it's affecting the patient, this psychotic manifestation in comparison to controlling the seizure. So if it is significantly affecting their life, so starting with vitamin B6, as you mentioned, and after that we can introduce more mood stabilizer, or if it is related to mood. However, if it is start to have a psychotic manifestation, I think that is an alarming sign to switch the medication. Okay, the second question, so if a patient on multiple anti-seizure medication side effects.
I'm sorry, can you say that again?
Yeah, if a patient on multiple anti-seizure medications, can the interaction treat each other behavioral side effect?
Can the interaction treat each other? Yeah, I think that was the case I just showed. So if you keep in mind the profiles and the general, Gabaergic and anti-glutamatergic, you can sort of balance it a little bit. So that person that I just mentioned, you essentially treat the side effects of topiramate with the side effects of lamotrigine. Obviously, that shouldn't be. It's like that. It's almost, you want to avoid being in that situation unless you have to, because the third component here is seizure freedom. So if a medication is very valuable for you in terms of seizure freedom, which also affects cognition and behavior, then you can try to balance. And it's much better than choosing your anti-seizure medication randomly, right? Because people just, you switch and switch and switch. And people, today I had somebody who tried 11 anti-seizure medications in poorly chosen combinations and doses. So yes, you can. Having said that, polytherapy does increase the risk of incurring side effects. So you want to be careful and rational about doing so. And this is how you do it, by knowing how the medications behave.
Sure. So the third question, how can we manage patient with suicidal thoughts? Should we treat or discontinue the causative anti-seizure medications?
Yeah, this is a tough question. First of all, I think the most important point here is to ask people and to screen people, especially if they are on anti-seizure medications that may be associated with depression, irritability, especially if they have psychiatric symptoms. Make sure you gauge whether the patient is telling you everything or not. Sometimes our epilepsy visits are routine medical visits, right? How are you? How are your seizures? Are you doing well? Okay, bye. So that's, and if you spend 2 more minutes or pull the patient aside or pay attention to the patient's face or body language, instead of having to just typing away on your medical record screen, you will notice some of this stuff. One alternative approach is to have screening tools. So there are a few screening tools out there for suicidality. You can definitely have a COLI questionnaire in your clinic in order to screen for those. And then take it seriously. We neurologists may be uncomfortable with talking about this stuff or dealing with it. So if somebody doesn't feel comfortable, immediately involve our psychiatric colleagues, or even send people to the emergency room if things seem imminent. Some of the important risk factors is whether there's a plan, whether people have access to the method, whether they have completely thought it out. And, I would definitely deal with it right there and then. The least important problem is to, one wants to obviously get rid of the medication that caused this after making sure that it's the medication that caused it. So I don't, it doesn't make sense to wait if somebody has suicidal thoughts that I know have no other underpinnings than the anti-seizure medication that I'm giving them. Having said that, that's like the least important intervention here, because we have to make sure that our patients are safe, and sometimes they even need to be admitted. There are times when there are many times when there are comorbid psychiatric syndromes that are not managed properly or not even diagnosed. And at that point, a joint evaluation by neuropsychiatric and neurological expertise becomes crucial. Yeah.
Thank you. Yeah. So the next question, what is the risk of developing psychosis with Laviteracetam or perampanel in a patient with ictal or post-ictal psychosis? And should we avoid them or be cautious in this type of population?
I would do that. Yes. I mean, I think that what we learn from the information is that the bigger the network involved and the bigger the epileptic network, the higher the risk of developing negative cognitive and behavioral sequelae. Evidence to that comes from intractability being a marker, secondarily generalized seizures, and history of psychiatric syndromes. To me, post-ictal or intra-ictal psychiatric symptoms are they share a lot with so-called primary psychiatric disorders. We know what's causing this one. We don't know what's causing that one. That's the only difference. So I think I would definitely be cautious about prescribing Laviteracetam in somebody. In fact, another case just came to mind about with somebody who had post-ictal psychosis who got prescribed Laviteracetam and just had constant psychosis. And then you ask yourself, is this aura continua or is this post-ictal psychosis? It's just a complete mess. So even if it weren't a risk factor, I would not prescribe a medication that potentially causes this, because it will confuse your picture. If that happens, you won't know whether your patient's seizing or not. I'm not sure. It's a nuanced point. So you want to avoid it even if it weren't a risk factor, in order to make it easier for you to judge what type of episode you're dealing with.
So the next question, what's your opinion or your point of view in using these type of medication like Laviteracetam, perampanel in patient with ADHD?
Yeah, I mean, I think I wouldn't say. I mean, I want to give an answer that's enlightened by data, and I'm not sure. I would pull up the data on. We know that perampanel has a favorable cognitive profile. Having said that, you would worry about anxiety and irritability negatively impacting attention, and you would also worry about whether somebody on stimulants who's experiencing anxiety would have even worse anxiety when they have perampanel added or Laviteracetam. So even though these two medications have a reasonably favorable cognitive profile, I wouldn't necessarily be, I guess, I mean, this is just a personal opinion. It becomes a matter of judgment, and I can't say I have reviewed the literature of, there may be literature out there, so I'm sorry to say I don't really know.
Okay, thank you. The next question, is there any nutrients medication interaction with this type of anti-epileptic?
Nutrients?
Yes, I think that's
like food. Other than B6, I'm not sure there's we worry about food with some of our psychiatric medications. Do you worry about food in our medications? I'm not sure.
Not that
I don't. I mean, I stopped somebody's ginkgo. Just a few days ago, I stopped somebody's ginkgo biloba, which sometimes leads to a little bit of irritability. It's used as a stimulant, but I don't routinely screen what people eat. I'm curious whether people do, and if somebody does, please let us know. I'm not sure we have the answer.
Exactly. So another question, in patients with SLE, they are at risk of developing neuropsychiatric lupus. So what do you recommend from the anti-epileptic if they are having seizure and they are at risk of this neuropsychiatric?
Yeah, I mean, I don't know. I think the question is what proportion of patients with lupus develop neuropsychiatric symptoms. I would, perhaps as neurologists, we're a little bit biased towards seeing the neuropsychiatric complications and the vasculitis and the vasculopathy and so on, because they get referred to us. But there's a lot of people out there with lupus who do not have these things. So, I would apply to lupus what I would apply to other illnesses. That would be my answer.
Sure. The last question for today. So what is the percentage of having depression in patients with topiramate?
The percentage of people with depression, it's something like 5% or something in that order. People will develop irritability and word finding difficulty more frequently than topiramate. I think that's high. 5%. If you prescribe, that means in every you'll have 2 patients out of every 50 patients or something like that. And topiramate is out there and available and so on. It's a shame because it's a really effective anti-seizure medication. I like topiramate. It makes you thin too. So
yeah. Yes. Okay. This was the last question. Thank you, Dr. Hitham, for the presentation, and thank you all for your joining. And we are more and more would like to make more talk about the cognitive and psychiatric manifestation of anti-seizure medication, because it's very important in the epilepsy clinic. So thank you for your time.
Thank you, Abir. Thank you to the Saudi Epilepsy Society and to the organizers and to the audience, of course.
Thank you. So this is the end of our talk. Thank you all for joining us today, and we promise you of having more and more activities under the umbrella of Saudi Epilepsy Society. Thank you and have a good night.